And here you're able to stain the amyloid deposits in the chelated group versus the non-chelated group. And they did not find any toxicity. This was published in the journal Neuron. Let's talk about humans. I mean, why not consider doing it in humans? And in fact, this study published in the Archives of Neurology looks at this attenuation of metal-protein interaction targeting beta amyloid in Alzheimer's patients. They did treat patients with severe, I need to put an E after severe, with clyoquinol. This is published back in December of 2003, and they measured things like amyloid excretion, zinc and copper levels every 4 weeks. And what they found, interestingly enough, was that zinc excretion zinc in the plasma increased, that beta amyloid levels decreased with time. But perhaps here's the payoff. This is change in the neurocognitive function of Alzheimer's patients who were treated with a metal chelating agent. Their degree, interestingly, early on at the 12-week point, they actually improved their cognitive function. They improved as opposed to the group not receiving it. But their rate of decline remains always well above the group not treated. Well, this clyoquinol is already an agent that is used as an antibiotic, but it's been banned in Japan because some cases of this subacute myelooptic neuropathy happened. It's thought that perhaps that using clyoquinol could still happen if patients were pre-treated with vitamin B12. It isn't a recognized treatment or available as yet in this country, but nonetheless, I think it's important to think about the fact that we don't have memory drugs. That people talk about taking these various things that you see advertised on the evening news. That isn't reality. Those medicines do not work. I see patients every day in my office who've had head trauma and are put on Aricept, who've had a stroke and are put on Aricept. Where is the science behind that? I mean, Aricept is a cholinesterase inhibitor, right? Because we know that the Alzheimer's brain is low in acetylcholine. So if we can have more acetylcholine by blocking the enzyme that degrades it, that might help these people. Well, it doesn't, but that's the theory. So why on earth should people be using it who have vascular dementia or stroke or head trauma? But people look upon it, based upon the advertisements, as a memory drug. Well, it doesn't exist yet. But yet, we know that things like DHA can improve the function of the hippocampus. DHA, non-prescription, people can buy it at a health food store or at your pharmacy. DHA leads to improvement in function, leads to dramatically reduced risk of Alzheimer's, and actually, via the pathway I showed you using a brain-derived neurotrophic factor, increases the growth of cells in your hippocampus. And that's available today. It's been available since humans began moving from the inland areas to discover the coastline and eat marine-based proteins. Dr. Barry Sears, in his new book about inflammation, you know Dr. Barry Sears, the Zone Diet, in his first chapter, he talks about the fact that probably 15,000 years ago, there was this dramatic jump in human intelligence. He credits that with humans learning to catch marine species that they ate that had high levels of DHA. So again, we've got to focus on treating the underlying problems, treating the inflammation, upregulating mitochondrial activity, and not just focusing on the smoke. So this is our task then. And at the end of the day, I think that it's a noble task. Whereas, you know, the individual patient may not recognize for 20 or 30 years what you've done for him or her. Or they may recognize it in 15 minutes when you upregulate glutathione or you give glutathione and target their mitochondria. So I think that's my presentation.